Okay, so this next lecture is going to start on our objective data or our physical exam for the respiratory assessment. So when you're looking at your patient, obviously we're going to start with your general survey and inspection. So that begins right when you walk in the room. In terms of positioning your patient, this is kind of important because you want to make sure that you have your patient, number one, comfortable, number two, so you can see them, and number three, that they can get good lung expansion when you're listening to them. So right away, as I mentioned, when you walk in, you're going to do your general survey and inspection. So you're going to look at them immediately, look at their face, look at their skin, look at how they're breathing. Are they short of breath when you look at them? Do they, look pale? Do they look like they have cyanosis? Do they, just kind of pulling all that information in together when you walk in. Are they sitting up in the bed, versus laying? Do they have two pillows behind their head? Because a lot of times patients with lung disease will have multiple pillows behind them so they can sit up. It makes it easier for them to breathe. A huge thing that a lot of people are, or I guess what I want you to make sure that you're doing is making sure that you can actually see your patient. You want to make sure that, you look at their chest and look at their skin and have, them remove their gown or partially remove their gown so you can look at their lungs and their back and their skin and all that. So as I mentioned, inspections that direct, it's very critical, very purposeful observations. So you're not just taking a quick glance at the patient, you are going to look at your patient really thoroughly. You're going to look at them and see, like I said, their coloring. You're going to look and make sure they don't look like they're short of breath or taking these huge deep breaths, looking for hypoventilation, hyperventilation, looking at their vital signs. You want to look at their pulse. Is their pulse super high? Because a lot of times if patients are respiratory distress, where they're having with like the hyperventilation, a lot of times their heart rate's going to be high. Sometimes their BP will be high with it. So you're going to look at all that data and kind of put it together. And then look for any deviations that you're going to notice. So they should appear symmetrical when you look at them when you walk in the room. And they should have that normal configuration of their thorax. So you shouldn't see one side expanding good, the other side not, or any major deformities that you may see there, you have to account for as well. So if you see a patient with scoliosis, things like that can affect their lung expansion essentially. So you got to look at all that information. Look at their skin, look at their accessory muscle use. You may see retractions. Retractions, you'll see this commonly in the child. A lot of times they'll pull in, and that's where you'll see those basically like the muscles are pulling in by the ribs or in between the intercostal spaces, and you actually will see that on your patient as well. Like I said, too, you can look up in the older adult, too. Sometimes you'll see it above the clavicle, above the sternum, or in their neck if they're having a difficult time breathing. Level of consciousness is another one, and we'll kind of look at that as well. Because you can have respiratory distress that a patient's hyperventilating, and then you can also have respiratory failure where the patient's not breathing enough, so it can go either way. So you really got to look at all of it and put that picture together. Like I said before, we talked about this with skin, peripheral cyanosis, and this is decreased peripheral circulation. And this is basically with clinical situations that lead to an increased arterial oxygen extraction. So when you're seeing these changes in the skin, fingernails, fingertips, and they're having more of that peripheral circulatory issue versus central cyanosis, which we talked about before, this is because of unsaturated arterial blood. So it's not with peripheral; they're oxygenated, but it's more of a perfusion issue. Central is where it's unoxygenated or it's lower than it should be. Or abnormal hemoglobin. And that's where they'll get that central color of blue, where by their tongue and lips. And this can be a circulatory issue or a ventilatory problem. That ruddy appearance, like we talked about before, that would be like erythema, prolonged hypoxemia with erythrocytosis. You'll see this a lot with patients that have COPD or chronic lung disease. They actually will end up with elevated hematocrits, sometimes even hemoglobins. You'll see it in smokers too. Smokers can have an elevated hemoglobin and hematocrit, and it's basically because of compensation. We'll talk about that a little bit later too. Just recognize that cyanosis is basically a late sign of respiratory dysfunction. If your patient has cyanosis, there's a major issue going on, and that's really a late stage finding that we really need to find earlier prior to that. Typically, like with cyanosis, they're having a huge amount of unsaturated hemoglobin, Remember, your hemoglobin is saturated with oxygen, which is oxygenating our tissues essentially. And this is what we use the pulse ox for. But a lot of times with cyanosis, it's not, you really can't see it until like their pulse ox is at like 85%. So that's not good. That's why I'm saying we got to catch it earlier before they even get to this point. Looking at the degree of effort, and like I said, this begins upon inspection. So dyspnea, and a lot of times with dyspnea, these patients will use accessory muscles like their neck and shoulder muscles. Like if you look at this patient, you can see it kind of pulling in, and it'll be real tight, and then it'll retract in a lot of times with breathing. In younger children, like I said, you'll see it in between their intercostals. You'll see it at the bottom by their diaphragm. And even when you look at your patient, like trying to get out of bed or walking across the room, can you see that they have dyspnea with it? Pursed lip breathing, this is on expiration, and this is common with emphysema. So when they breathe in, they'll do a quicker breathe in, like of a 1-2. But when they're exhaling, they'll actually, if you can see this image, they purse their lips like they're whistling. And it's a lot longer than when they inspire. So expiration, they're trying to blow all that CO2 off so that it's longer, like a 4-second basically breath off. So you'll see this more commonly with those disease states like emphysema. Nasal flaring, I know we talked about this in the first module, but this is common in kids. You'll see like the external nares kind of going out when they're trying to breathe. That's usually a signal of dyspnea. Orthopnea. Orthopnea is very, very common. Like I said, when they lay down, they feel short of breath. So orthopnea is what we label it as when they're lying down. So it's shortness of breath while lying flat. Paroxysmal nocturnal dyspnea, I know I mentioned this a little bit earlier. This is more related to CHF, but remember with CHF, they can get fluid on the lungs. So when they get fluid on the lungs, they a lot of times will get it at night. And the reason being is because with CHF, remember that they get that, they'll have fluid retention, and a lot of times it's either goes to the lungs or to their lower extremities. When you're lying down at night, all this fluid ends up coming off or comes off the legs, and then end up with fluid overload into the lungs. So that's why it happens at night, because they start getting that return circulation or pulling that fluid back up, but then it ends up in the lungs. So then at night, they wake up and they're short of breath with it. And that's what we call paroxysmal nocturnal dyspnea. Nocturnal meaning night, dyspnea, like shortness of breath and difficulty breathing. So like I said, when you lay down, if you think about it, all that fluid from the legs that they had fluid retention with will come back up, and then it goes back into circulation and then ends up in the lungs. So then they get that fluid overload at night. And that's what that is essentially. So when you think about the muscles of respiration, like I mentioned at the beginning, it's usually our diaphragm and intercostals. So you really want to look at those muscles when you're examining them. Your intercostals are basically going to lift your sternum and elevate your ribs. So all of that's going to pull all this up. So when you're inspiring, it'll open that thoracic cage up, and it increases that AP diameter. Expiration is mainly passive. But unless they're getting that pursed lip breathing where they're actually trying to blow out more. So when the patient has more of a forced inspiration, they start using those other muscles like your sternocleidomastoid and your trapezius. So when they're trying to breathe in and they're having difficulty with it, these accessory muscles start kicking in to support inspiration when they have dyspnea, essentially. So when you're a patient that's trying to blow off more, like I said, when they're having issues with expiration, they may use this pursed lip breathing, or sometimes you'll see the abdominal muscles kick in because remember your abdominal muscles will help with your diaphragm pulling it down and pulling it up or pushing it back up. So those you might see when the patient's having a hard time, exhaling. But typically, most of the time, it's more of the inspiratory issues that we deal with. And that's why you always have to check your, all the accessory muscles that are helping respiration, essentially. In terms of rate of respirations, I know I have a video up there, and I think it says anywhere from 8 to, 16 or something like that. Your textbook says it's 10 to 20, so just go by that. You always, with anything, whether it's your heart, listen to your pulse or your respiratory rate. If anything is off, you're always going to do it for a full minute. But prior to that, you're going to do it, you do the 30-second times it by 2 count. But if it's off, like I said, you're always going to do a full minute. And you don't want your patient to know that you're counting the respirations because it does alter them. We call tachypnea is any time the respiratory rate is over 20. This can happen with anxiety, pain, or it can be your first indication for respiratory distress. So you really got to put it in the context of what your patient's presenting with. Like I said, tachypnea is your rapid respiratory rate. It sometimes can be related to a temperature or an underlying disease process. So if they have asthma, if they have COPD, if they have CHF that has fluid overload on the lungs, sometimes you'll see tachypnea with it. You'll see tachypnea in kids a lot. If they're sick with certain viruses, sometimes you'll see it. You'll see it in the newborn a lot because a lot of C-section babies will have, they don't get the fluid pushed out of their lungs good, so they'll have tachypnea at the very beginning. You'll see it in peds a lot. Bradypnea is lower. Remember, brady means slow. Tachy means fast. So bradypnea is less than 10. You may see this, like I said, with any intracranial process. If they had a hemorrhagic stroke, or if they had a traumatic brain injury or an aneurysm, anything that's going to alter the pressure within the cerebral hemispheres, essentially, it could put pressure on the brainstem and all that, and then it depresses the respiratory center. Another area too is narcotic overdose. Like we mentioned, I know we kind of talked about this in pharmacology, but narcotic overdose, that respiratory drive and all that. So bradypnea means lower respiratory rate. Hypothermia is another one that can cause it, but neurologic disorders are one of the common culprits of this. So it's just something to kind of think of, or even like sepsis and stuff like that too. So as I mentioned, when you're checking your rate of respirations, they shouldn't be aware that you're counting it. A lot of times you'll do their pulse, but then immediately go right into checking the respiratory rate, and your patient still thinks you're checking their pulse. So it's just kind of making sure that they're not aware yet you're doing it, because it can throw it off. In terms of men and women, a lot of times men are more abdominal breathers and women are more thoracic. I don't know, it's just a little tidbit of information. So when you're looking at a male versus female, you might see more, if they're having distress, you might see more retractions in the thoracic area in women versus the abdomen in men. So chest wall and abdomen expand during inspiration, and it should be symmetrical. So when you're doing that inspection, you're looking for symmetry. You should see symmetrical breathing. You should see it both sides rising at the same time. You shouldn't see just one side, because then you're worried about something going on one side of the chest. Periodic deep breathing with sighs, it's normal. I mean, if the patient has it a lot, then we're looking at something different. But if you see it less than basically a couple than per five, if you see a few of them in less than 5 minutes, or less than 5 per minute, it's pretty normal. I mean, I don't know. You'll see it a lot in kids too, or little ones, little babies' size you'll see frequently, and it's usually not related to anything. Rhythm of respirations, like I said, you have to look, when you're looking at that rate, you also want to look at the rhythm. Are they having hyperventilation? Are they having hypoventilation? So normally regular cycles with expiratory phase are slightly longer than the inspiratory, so that's very common, that's normal. But like I said, you want to make sure that their chest movement is equal, bilateral, and symmetrical. So it should look the same on both sides. You should have normal chest expansion. So as I said, you look at hypoventilation or shallow breathing, even if their rate is normal, because that can cause them a problem. They may have a normal rate, but they're shallow breathing, and that could be an issue. Two common areas that I wanted to just talk about real quick before we talk about abnormals, rhythm of respirations, Kussmaul respirations. You may see this kind of at end stage of life. Actually, Shane Stokes is kind of what you pretty much see at the end of life, but Kussmaul breathing, you'll see it a lot with metabolic acidosis or diabetic ketoacidosis. And with this, it's very regular, as you can see. Kussmaul breathing, they'll have regular breathing, like up, down, up, down. It's very fast, though. It's very rapid, and they're very deep. If you YouTube it, like on, if you go on YouTube, you can actually look up some videos and see. They'll have videos of patients with Kussmaul breathing. But it'll be very deep, very regular, though. So that's the difference. Where Shane Stokes respirations, they're going to have apnea. They'll have periods where there's nothing, and then it's going to be periods of fast breathing, essentially. So a lot of times you'll see this with the end stage of life. A patient that had a stroke, a patient they had an MI, with any cerebral injury or hypoxemia, you may see this. So it's very irregular. So that's the difference between the two of them. You always want to look at your patient's mental status. If they have any confusion that's new and you walk in the room and they seem confused or there's an alteration there, you do want to always think about hypoxemia in the back of your mind. So if they are having difficulty breathing and they're confused, then you got to make sure that that's something that's brought up to another provider. Any inappropriate behavior, drowsiness, so they may be the opposite. Instead of being confused, they may not be responsive to you. So that's a huge red flag. So any change in their mental status is something to think about. So inspection of the posterior chest, like I said, you are going to look at the shape of it, the configuration of the chest wall. Does it look even? Is it symmetrical? Do they have, normal inspiration, expiratory? Is it all going together? Is it symmetrical? Like I said before with COPD, the AP diameter, the anterior posterior diameter becomes closer to 1:1 versus a, more oblong chest, essentially. So they get that barrel chest. And actually you can see it here in this patient. And it may not be, you may not notice until you actually have, that's why it's so important to have your patient in a gown, because you can't, take off their gown and look at their chest, because you really wouldn't possibly notice this. But you can kind of see how it's barrel chested here. It's a little bit more rounded out versus it going down here instead of, it would be short. So it's longer with, those chronic pulmonary diseases. You may see patients sitting in a tripod position. This is common with pulmonary conditions. They lean forward and they have their arms usually on their knees. And it just kind of helps them breathe easier. So it's something that you may see in your patient. Like I said, you're going to look at the neck and trapezius muscles. So the anterior posterior diameter should be less than the transverse diameter. So your AP diameter is going to be less than your transverse. Transverse would be going from this side to that side versus AP. Your AP is from front to back. Symmetric expansion, like I said, this would be, I don't think she's going to have you do this in the lab, but a lot of times you can do this just through looking at your patient and making sure that they're, have symmetric respirations there. So there's another test that you can do, and you're basically putting your hands you put your thumbs basically by their spine or the spinous process, and you put your other hands at the bottom of their rib cage, and you're going to put your hands together in the middle and have them inspire and expire, and your hands should raise equally when you're doing this. I don't think you have to do it in the lab, but it's something you may want to practice just to kind of look at. So if you do have, an asymmetrical expansion there, one hand's going up and not the other, you might be concerned about like a pneumothorax or something like that, because one side's not expanding as well as the other, essentially. In terms of palpation, this is another technique that we use, and what we look for is tactile fremitus, and basically that's for feeling for vibration. So you're going to use the palm part of your hand or the ulnar edge. And you basically have the patient, you're going to put both of them, I'll have the image on the next slide, but the patient will repeat 99. So you have them say 99 in each area, essentially. And you're going to compare each area like you do when you auscultate. And it's going to get that vibration there. So the voice sounds are transmitted through your airways, and you'll feel it as a vibration in your hand. And most of the vibration is transmitted through the larynx, essentially. So, but with decreased fremitus, we're looking at an obstruction of the vibration, or obstruction in the transmission of the vibration. So you're not going to feel the vibration when there's obstruction, and that would be decreased fremitus. You may see this with like emphysema or pleural effusion because they're not getting good airflow through there. They're not getting they're just not getting good airflow through there. Increased fremitus would be with consolidation. So like if you had a patient that's been really sick, or they have pneumonia where they have a lot of consolidation in their lungs, you're going to have an increased vibration in there because of all the potentially like fluid or, sputum or something that they have in their chest. And you're going to check for symmetry. That's why I always say too, you're always comparing both sides, left to right, right to left. Do they feel the same? Because if one side has increased fremitus and the other doesn't, then you might think, okay, well, on the right side they have it. Maybe they have pneumonia going on that side. Versus decreased fremitus would be reduced vibration with it. And you're also looking for symmetry when you do this. You're also feeling the patient's skin temperature. Do they feel warm and clammy? Are they sweaty? Do they feel like they have a temperature? Do they feel cool? And looking at their skin as well. So you can even do your skin exam while you're doing this too. You typically hear the most of the time for tactile fremitus, it's usually most prominent between, I'll show you an image, but it's usually most prominent between your scapula and between there and your sternum. Because a lot of times this consolidation, or where you actually feel the vibration, is coming from, like I said, like the larynx and your bronchi, because that's where the major air flow is coming through. So you're going to feel more of an increased fremitus when you feel towards, their sternum. Or if you're going from the back, you'll feel it more between the scapula, essentially. So that's where you commonly will find tactile fremitus. It does typically decrease like as you go down the chest, because the density of our lung tissue will impede that vibratory feeling that we pick up over the bronchi. So the further down you go, a lot of times it's typical to have a decreased fremitus as you move down the chest, essentially. Here's an image of it, just like the marks that you're going to be doing with auscultation. You're going to go, you always go from one side to the next and then move down, because you're going to compare, you want to compare right to left, like I said. So you're starting here, then you go here, then you go here, here. Same thing, and that's how you're going to take the same approach with auscultation. You're always going from left to right, right to left, because you want to compare. So like I said, you'll have typically more decreased fremitus down here, because the vibratory sensation actually takes place more because of the major airways. So you're going to have increased fremitus up on the topper part. A lot of this you don't have to do in the lab, but it's just a good area to kind of understand. So the patient will say 99, and when they feel 99, you should feel that vibratory sense under there. In terms of percussion, I know they'll have you practice this in lab as well. And basically what you want to do, again, once again, you're comparing sides. You're going to be comparing certain areas from left to right. You're always going to start at the lung apex, and it should be resonant. So normal lung tissue should be resonant. And then you always are percussing between the intercostal spaces as well. You're not going to go over the bone, because if you go over the bone, it's going to be a different side or a different sound. You're always going side to side, and then every time you're doing percussion, you usually tap like 2 to 3 times to get a good listen to that sound. You're going to avoid the scapula and ribs, like I said, because it's going to damper the sound that's there. And like I said, resonant tissue is normal. It's normally low pitch. It's more of that hollow sound, and it really takes practicing this to kind of get a good handle on what the sound sounds like, essentially. So resonance is what will be in healthy lung tissue typically. In order to even pick up percussion notes that are different or abnormal, it really needs to be a relatively large area of consolidation or a lesion, within the lung, or for instance, if it was a tumor, it has to be pretty big before you can even pick it up on percussion. A lot of times nowadays, honestly, percussion of the chest and thorax is relatively uncommon, because now we have so many diagnostic testing between X-rays and CTs. A lot of times if you're suspicious of something, they get sent for, an X-ray or CT. But it is a good quick method to kind of do, looking at it. We use it a lot for the abdomen, but it's just something to be knowledgeable about. Like I mentioned before, lung sounds are going to be resonant. This would be dull, because remember where the liver is. We'll get into that later, and it'll change to dull once you get over like an organ or a bone or something like that. So it'll be more of that hollow sound with it. So dull sounds are normally heard over areas like your bones or your heart or a liver, like a solid liver, or a solid organ. If you're hearing dull in the chest, that's when you're concerned about consolidation, such as pneumonia or pleural effusion. So you should normally hear resonance. Hyperresonant sounds, so just think of it that way. Resonant is normal in the lungs because it has air in it. Hyperresonant is going to be louder but lower pitch, but it's going to be because the lungs are hyperinflated. So a lot of times with COPD, these patients maintain a lot of air in their chest cavity. So a lot of times they'll have hyperinflation with it as well. One thing I wanted to go back to is crepitus. This is different than fremitus, because crepitus is, you'll feel like a crackly, crunching feeling within, like on the chest wall. And this is because air is in the subcutaneous tissue. It's not crepitus. You don't feel crepitus from inside the lung. It's because it's in between the chest wall, essentially. So a patient that may have had surgery or, trauma to the chest wall, some air may have escaped from the thoracic cavity and maybe in between the subcutaneous tissue. So that's where you feel crepitus. Crepitus is if you were to put your hand over your knee and have an open, not everybody's knee, but a lot of times as people get older, you'll feel it. If you put your hand over your knee and flex and extend your knee, sometimes you'll feel that crunchy feeling, and that's kind of what crepitus feels like. But this is not related to an intrathoracic process. It's related to air in the subcutaneous cavity. I just wanted to go back to that to mention that. So that will conclude the lecture on this, and next I'm going to go to lung auscultation, and that'll be on a separate lecture. Thanks, and let me know if you have any questions.